Addressing a hip dislocation and plus minus femoral head fractures. So a hip is a ball and socket joint, allows wide range of motion, but also is highly constrained, has a stable labrum and large muscles around the hip joint as well. The hip joint has good strong ligaments, that is iliofemoral, pubofemoral, and ischiofemoral ligaments. The vascularity is also important, with the medial lateral circumflex artery giving blood supply to the femoral head. Associated injuries with the hip dislocation: 95% has associated injuries, that is head injury, craniofacial injury, thoracic injury. Trauma general surgery evaluation is warranted in these cases. Sciatic nerve injuries can be associated 10% of the adults and 5% in the pediatric population. The perineal component is mostly involved. The mechanism can be motor vehicle accidents, fast pedestrians struck by vehicle, or industrial accidents or sports-related injuries. Posterior dislocations are 90% and 10% on anterior hip dislocations. The mechanism is in posterior hip dislocation, the hip is adducted and internal rotated. It leads to pure hip dislocation. The lesser the adduction or lesser the internal rotation, more preponderance for a fracture dislocation. In the anterior hip dislocation, the hip is hyperabducted and extension. Position of the hip determines the type of anterior hip dislocation. A hyperflexion of the hip will cause inferior obturator dislocation. A hip extension would cause anterior hip dislocation over superior ramus. In a physical examination, the posterior dislocation, the hip is flexed, adducted, internal rotated, and shortened. This may differ if there is a neck or shaft fracture. In anterior dislocation, the hip is external rotated and abducted. If there is a fracture, shaft or a neck or a femoral head, the examination finding may differ. Regarding the radiographic elevation, AP view, pelvis X-ray, ATLS protocol following is mandatory. If the hip is dislocated, you need to determine the direction of the dislocation. In the posterior dislocation, the femoral head is smaller and commonly overlaps the acetabulum. The femoral rotation you can check also, which will be adducted and internal rotated. In anterior dislocation, the head is larger. Radiographic evaluation is important. CT scan can be advised if delay cannot, if there is no delay. Any femoral neck fracture with femoral head dislocation, a surgical stabilization is done prior to manipulation of the dislocation. Regarding the classification, the posterior hip dislocation classification is Thompson and Epstein. Number 1 is pure dislocation with or without minor fracture. Type 2 is with a single large posterior wall fragment. Type 3 is dislocation with a comminuted posterior wall. Type 4 is acetabular floor fracture. And type 5 is dislocation with femoral head fracture. Regarding the hip dislocation fractures, it's classified by Pipkins. Type 1 is infrafoveal, type 2 is suprafoveal, type 3 is femoral head fracture with associated femoral neck fracture, type 4 is femoral head fracture with acetabulum fracture. There is an anterior hip dislocation classification called Epstein classification, which states type 1 is superior dislocation, type 2 is inferior dislocation. Reduction timing is more important. Event risk is 5-fold if the reduction is done more than 12 hours delay. This has been shown by Kellam et al. 2016. Some have indicated less than 6 hours of reduction. For example, Melham 2000 core. The patient should be fully relaxed before the reduction attempt. For a posterior dislocation, LS maneuver is mostly utilized. Patient is supine, traction and counter traction technique. Assistant provides downward force at the anterior and superior iliac spine. Surgeon flexes the hip and the knee and then put a longitudinal force. Start with the extremity in interrotation adduction. Gently rotates the extremity towards during traction. There are other many techniques such as Stimson technique. Stimson is a similar like gravity maneuver where the patient is prone. A Bigelow technique has been also documented. East Baltimore lift is one which is done by multiple assistants used to provide traction. Regarding the anterior hip dislocation, a reduction technique is called Walker modification. The patient is supine. For inferior dislocation, there is a continuous traction which is given. Then gently hip is flexed and lateral force on the inner thigh is given to relocate it. For superior dislocation, a continuous traction in gentle internal rotation is given. Extension of the hip may be required, having a bump ready to allow for this. Continuous traction is better than short jerky movements. If the hip is stable after the reduction, which should be assessed at the intraoperatively, then conservatively patient can be managed. Small fracture fragment in the cotyloid fossa can be tolerated well as long as joint is concentrically reduced. Posterior hip dislocation precautions is limited adduction and interrotation and flexion. Early mobilization, touch down weight bearing for 4 to 6 weeks and repeat X-ray before allowing full weight bearing. Indication for operative intervention in hip dislocation is irreducible hip dislocation with femoral leg fracture, incarcerated fragments in the joint space, incongruent reduction, and unstable hip dislocation after reduction. In anterior dislocation, if the hip is irreducible, the possible causes can be: number 1, femoral head buttonhole through the capsule; number 2, rectus femoris; number 3, labrum; number 4, psoas tendon. In posterior irreducible hip dislocation, the possible causes can be piriformis tendon, obturator internus tendon, gluteus maximus, posterior capsule, ligamentum teres, posterior wall and bone fragments, iliofemoral ligament, and labrum. If there is a Pipkin type 1 femoral head fracture with dislocation after the reduction, if the hip is stable, continue with the non-operative treatment. In Pipkin 2, if the head dislocation has been reduced, a Pipkin 2 fracture femoral head can be managed non-operatively until it is anatomically reduced. There is still risk of redisplacement, which is shown by Butler in 1981 and in 1992. Important factors to consider operative intervention is size of the femoral head fragment, shear injury versus impaction injury, and presence or location of incarcerated fragment and associated posterior wall acetabular fragment. Free fragment between the femoral head and acetabulum needs to be removed. A pre-op CT can help to determine the donor site. Small eversion of the femoral head can be removed. A Pipkin Type 1 fractures that aren't reduced should be removed. Loose fragment from the posterior wall acetable fragment should be removed. Arthroscopic debridement is another option. For posterior wall acetable fractures with the femoral head dislocation, a Cocker-Langenbach approach needs to be employed with the ORIF of posterior wall. Excision of posterior femoral head component with the posterior approach is advisable. For anterior dislocation, Smith-Peterson or Hutter interval or anterolateral Watson-Jones technique are advisable. The Watson-Jones is often preferred for irreducible anterior hip dislocation, as farther from the possible abnormal position of the femoral neurovascular bundle due to the femoral head. Supine position is mostly commonly placed. Leg free allow hip flexion and other hip position to visualize the fragments. In Pipkin, 3 type of fractures treatment is operative. In a patient with a hip dislocation and femoral neck fracture, always in young population, always go for a ORIF of the femoral neck before reduction. Consider arthroplasty in a physiologically and chronologically elder patient. So always, if there is a neck fracture, it's always advisable and better if it is undisplaced or minimally displaced, the fixation should be done while the hip is dislocated and then reduce the dislocation. In Pipkin 4, a successful treatment needs femoral head addressed and acetabulum addressed as well. Anterior approach can be visualized for femoral head fractures if location and size warrant, or a staged posterior approach for acetabulum may be required. It is important to do a CT scan to find out the femoral head component, whether it is anterior or posterior. If there is posterior, we need to go on for the Cocker-Langenbach approach, while anterior, we need to go on for a Smith-Peterson approach. ORF can be done with the screws. Regarding the avian rate in Thompson-Epson classification system, type 1 has 10% avian risk, type 2 is 17%, type 3 is 27%, type 4 is 43%. In anterior dislocation, the post-traumatic avian rate is about 15%.